டாக்டர் பிரதீப் ரொம்ப ஆக்டிவா வந்து இதுல பண்ணிட்டு இருக்காருல்ல சார், ஜெனடிக்ஸ் இதெல்லாம் நல்லா பண்ணிட்டு இருக்கீங்க. வெரி குட். ஆக்சுவலா நிறைய ஆக்டிவிட்டிஸ். ஐ திங்க் யூ ஆர் ரியலி எஸ்டாப்ளிஷிங் a landmark. ஐ மீன் ஒரு ஸ்டாண்டர்ட்ஸ் இன் கோயம்புத்தூர்.
Thank you, sir. Thank you, sir.
நான் யூசுவலா எல்லாரும் சென்னைக்கு தான் ஓடி ஆகணும், பட் யூ ஆர் டூயிங் a fantastic job in கோயம்புத்தூர்.
Thank you, sir.
இவங்க எப்ப பண்றாங்க? 12th பண்றாங்களா?
என்னங்க சார்?
12th
லட்சுமி நான் 12th சொல்லிடுவா சார்?
அது எனக்கு
இதோ நான் இப்ப நீங்க பேர் கேட்டீங்க தோறுங்க, நான் இப்ப மெசேஜ் அனுப்பிச்சு விடுறேன் சார். இதோ இப்போ உங்களுக்கு பேர் நான் அனுப்பிச்சு விடுறேன்.
சரியா 12th ஓகே.
ரைட் சார், அவங்ககிட்ட சொல்லிடுறேன்.
ஃபிஃப்த் மதுரை பண்றாங்க யூஜி. டாக்டர் பாலசங்கர் சார் பண்றாரு.
12th சார்?
இல்ல ஃபிஃப்த் அண்டர் கிராஜுவேட்.
சரிங்க சார்.
டாக்டர் பாலசங்கர் பண்றாரு.
சரிங்க சார். அப்ப வந்து 6th அவர் பண்றாருன்னா அப்ப அடுத்த வாரம் நம்ம இவங்கள போட்டுக்கலாம்.
5th and 12th வந்து ஐ திங்க் நீங்க சொல்ற போடலாம், லட்சுமி நாராயணா போடலாம்.
சரிங்க சார். பிஜி இப்ப எது வரைக்கும் சார் நம்ம முடிஞ்சிருக்கு?
பிஜி நெக்ஸ்ட் வந்து இன்னைக்கு நைட்டு ஸ்டான்லி மெடிக்கல் காலேஜ். அண்ட் 5th வந்து மேத்தா ஹாஸ்பிட்டல்.
ஓகே சார்.
அண்ட் 12th மதுரை மெடிக்கல் காலேஜ்.
ஓகே.
அண்ட் 19th வந்து பிஜிஐ சண்டிகர் பண்றாங்க.
ஓகே ஓகே ஓகே
ஓகே.
சோ அப்ப நமக்கு அப்ப 25 27
தண்ணி ஒரு டம்ளர்ல
27 இருக்கு. ஓகே, இது வரல. ஓகே ஃபைன். அப்ப 27 வரைக்கும் ஓகே. 27 தான் அப்ப நம்ம அடுத்த ஸ்லாட் வருது இல்லைங்களா சார்? நான் கேக்குறேன் சார், இங்க பாண்டிச்சேரியில இவங்க மகாத்மா காந்தி கேட்டிருந்தா, நம்ம இவர் சவுந்தரராஜன் சார் கிட்ட பிம்சம் கேட்டிருந்தா, அவங்க 27 யாரு இன்ட்ரெஸ்ட்னு கேக்குறேன் நான். கேட்டு சொல்றேன் சார்.
2 o'clock will start it.
ஓகேங்க சார். It's being recorded, sir. Just enabling recording.
Yeah. Good afternoon to everybody. It's my great pleasure and privilege to welcome you to this undergraduate case presentation. This is 12th case presentation. We are doing almost 3 months over. I think this program is going very nicely, and many students' feedback I got it is really benefited. So on behalf of IAP TNSC, I welcome Dr. Bala Murugan, and he was Vice President of IAP TNSC, and he was done excellent work during our tenure also. I welcome Dr. Bala Murugan. He is Associate Professor and Head of the Department of Pediatrics, Tanjavur Medical College. I welcome Dr. Bala Murugan.
Thank you, sir.
And I welcome Dr. Sendil Kumar. He's a Senior Assistant Professor of Pediatrics, Tanjavur Medical College, Tanjavur. I welcome Dr. Sendil Kumar.
Thank you, sir.
And next one is Dr. Pradeep Kumar. He's consultant clinical genetics, and he was basically he's a pediatrician, and he has done a lot of work in genetic also. I think one of the few persons in Tamil Nadu we are having a genetic from pediatric aspect, and currently he's a consultant at Kobe Medical Center and Hospital and a medical college also. I welcome Dr. Pradeep Kumar.
Thank you, sir.
Yeah.
Thank you, sir.
And I welcome Dr. Yoga Yalini and Sarin and Deva Dasni. So students, they are going to interact with you, and as well as Yoga Yalini, I think she's going to present their case today. And on behalf of IAP TNSC, I welcome all the students, and I welcome our Joint Secretary, Dr. Thirumurugan, who is coordinating this media. I welcome Thirumurugan also, and I welcome Anandal. And straight away, we can go for our case presentation. Over to Dr. Bala Murugan.
Yes, I. Thank you, sir. Thank you for introducing all. Straight away, we start the session, sir. We'll start that.
Good afternoon, sir.
Our yoga and we start it. We start presenting.
Good afternoon, sir.
Good afternoon.
A 5-year-old boy named Ram, brought by his mother from Tanjavur with good reliability, came with the chief complaints of cough for the past 1 week, fever for 3 days, and difficulty in breathing for the past 1 day. History of presenting illness: the child was apparently normal 1 week back. Then he developed a cough which was insidious in onset, progressive in nature, associated with expectoration, not mouth swelling, yellow-colored purulent discharge, no postural or diurnal variation, no aggravating or relieving factors, relieved on taking cough syrup. Fever for the past 3 days, which is of low grade, intermittent in nature, not associated with chills and rigors, difficulty in breathing for the past 1 day, no postural or diurnal variation, no aggravating factors, relieved by nebulization.
So what is your interpretation from this history of present illness? The first in this slide.
So in the slide, the
Just
patient
we'll
has
discuss. Yeah.
Yes, sir. The patient has a cough with expectoration.
Child is a known
Yes,
case already. Known case
yes,
of.
the child is a known case of Down syndrome diagnosed at birth, sir.
Yes.
Yalini.
So,
Yes, sir.
Sir. Sir, proceed, sir.
Yeah. That so there is a immunosuppression is there. Chances of immunosuppression is there. So fever, difficulty in breathing. There is some suspect some bacterial infection
Lower,
also.
yes, sir. Lower respiratory tract infections.
So most of the illness is due to viral illness, but this child is immunosuppressive. So what to think of the bacterial illness also? Right. So most of the common fever is viral only. Have to know it. Okay. So moreover that expectoration is yellow color and not foul smelling. Not foul smelling. So it may be mostly a viral. Mostly seems to be. But the difficulty in breathing seems to be something alarming. Yeah.
Yes, sir.
What is the nature of the fever?
So fever is a low grade and intermittent, sir.
Yeah. Okay. So according to what is your opinion about the fever? whether it is viral origin or bacterial origin.
So it will be viral in origin, sir, because intermittent in nature.
Okay.
Yes.
So,
Where will you get a fever with rigor?
Malaria,
The fever
sir.
is
Malaria, UTI.
yeah.
Sometimes rarely infected endocarditis.
Okay.
Malaria, urinary tract infection,
yes, sir.
malaria. Yes.
Yalini, one suggestion.
Yes, sir.
In the first line, child was apparently normal. You have put no.
Yes,
Try
sir.
to avoid that apparently normal in
Non-case
child with the chronic illness already.
Yes, sir.
Avoid that
Okay,
word. That may
Yes, sir.
catch the attraction of an examiner. So you know already there is a problem. So
Yes, sir.
better avoid that word.
Yes, sir. Okay, sir.
Proceed. Thank you.
Yes, sir.
Yeah.
History of fast breathing present. No history of running nose. No history of hemoptysis. No history of ear discharge. No history of vomiting or diarrhea. No history of constipation. No history of excessive sleepiness and difficulty awakening.
So, what is your opinion
Sir,
of
because since the patient
breathing?
has fever and cough, we ask other symptoms related to the respiratory system. And history of fast breathing is present, which is suggestive of mild pneumonia. And there's no history of running nose. Running nose is usually present in upper respiratory tract infections. And history of hemoptysis may be present in lung abscess or suppurative lung diseases, and rarely in pulmonary tuberculosis. And ear discharge we ask because there may be spread of infection via the auditory tube to the respiratory tract.
In Down syndrome also there is serous otitis media is
Serous
common.
otitis media. Yes, sir.
Okay. What is the IMNC criteria of pneumonia? To define pneumonia, how will you define pneumonia by IMNC?
Pneumonia, mild pneumonia is the presence of fast breathing without a chest in drawing. And in severe pneumonia, chest in drawing is present, plus a nasal grunting, stridor, and nasal flaring may be present, sir.
Yeah.
So,
What did you ask? Excessive sleepiness and difficulty in awakening?
Sir,
To rule out the congenital hypothyroidism, sir.
Yeah.
how
There is
common it is congenital hypothyroidism in Down syndrome?
5 to 15%, sir.
Okay.
any sleep disorder, in Down syndrome?
Obstructive sleep
Obstructive
apnea
sleep.
is commonly seen, sir.
Yeah. Okay. Why did you ask vomiting, diarrhea? What are the
So,
GIT problems you are expecting in this Down syndrome?
yes, urinary atresia is common in Down syndrome, sir. It will usually manifest as vomiting, sir. And diarrhea to rule out any GI infections which have been a cause for fever, sir. Constipation. Usually in Down syndrome cases, Hirschsprung disease is common, but it will be diagnosed at birth. But here it's asked to rule out hypotonia. So in Down syndrome, generalized hypotonia is seen, so bowel movements will be reduced. So history of constipation is common.
Celiac disease also
Yeah.
may be present in
Yes, sir.
However, constipation is one of the feature in hypothyroidism.
Hypothyroid.
Yes, sir.
Okay. Next slide.
next slide.
Sir, there is no history of pedal edema, oligural abdominal pain. There is no history of impaired vision. There is no history of impairment in hearing. No history of seizures. There is no history of nasal regurgitation of food. There is no history of bone pain. No history of gum bleeds or bleeding from any abdominal sites.
So,
You explain why you have asked all these
Sir,
one by one.
Sir, congenital heart disease is very common in Down syndrome. It is seen in 40 to 50% of cases. Hence, to rule out a heart failure, we ask pedal edema, oliguria, and abdominal pain. Impaired vision is also common. There may be cataract presentation. Cataract occurs in 15% of the cases, and also refractive error is seen in more than 50% of the cases. Also, nystagmus and squint visual abnormalities could be seen in Down syndrome. And impairment in hearing, both conductive
What is
and
the common
sensory
refractory
hearing
error?
loss.
What is the common refractory error in Down syndrome children? Myopia is common. Okay, yes, continue.
Impairment in hearing, both conductive hearing loss is seen due to recurrent serous otitis media, which is common in Down syndrome. And also due to narrowed internal acoustic meatus, there is a sensory neural hearing loss seen, sir.
Yes. Seizures?
And
Seizures is infantile spasm is seen, sir, in 13% of cases. And nasal regurgitation of food is due to incoordination of the pharyngeal muscles and due to hypotonia. And bone pain is asked for leukemia, bony tenderness is asked. And gum bleeds and bleeding from abnormal sites to rule out thrombocytopenia and hematological manifestations, sir.
Good, good.
What are the hematological manifestations you are expecting in Downs?
In less than 2 years, ALL is common, sir.
In less than 2 years, it is
AML is
AML.
common, sir, and greater than 2 years, ALL is common, sir.
Transient
and also transient
White
myelofibrosis is seen, sir.
Okay.
In this,
Anything?
proceed.
Yes, sir. Past history, the child was
I think in
diagnosed
the
at birth.
history of presenting illness, one more thing you can ask regarding the polyuria also. Sometimes the diabetes mellitus is also
early onset.
One of the endocrinological abnormalities. So polyuria history can also be included.
Yes, sir.
Then something related with some psychiatric problem like aggression, that also can be included. Since the age is 5 years, you can
Yes,
add
sir.
those features also like hyperactivity, aggression behavior, and
Behavior problems.
Yes,
that can also be included in the history of presenting illness. And one more thing regarding the skin manifestation, we can add a few more points. Sometimes like
Yes, sir.
pustulosis, follicle, so that can be included. And regarding the bladder control, we can inform that also because it's 5 years, no? Right?
Yes.
By this time, the bladder control would have occurred. So that can also be asked.
Yes, sir.
Okay. Proceed.
So in the history of present illness, before going to ask from the main history presenter, that is mother reliability, you have to check the reliability, and you have to know completely about the disease, the Down syndrome. So regarding that, all the system involvement, you have to ask all the history. So if you know the knowledge about the complete knowledge about the Down syndrome, you can ask the negative history and all. Okay, so you have to be thorough before asking the question from the mother. Okay, then you have, from the history of personal illness, you have to know about the what is the cause, what is the cause of the illness, whether it is a progressive illness or a static illness like that, and any the complications. So the what are three C's is important in the history of personal illness. That is, what is the course of the illness, what is the cause of the illness, and what is the complication, what are the complications you are expecting. So in the history of personal illness, you have to know about this. Okay, are you satisfied about the three C's from this history of personal illness? So already known case of Down syndrome.
Yes, sir.
Any complications? What are you asked all the complications? I think so. The course of illness is static. Child is improving well. I
Yes,
think
sir.
so. Any nutrition part will give any other child is whether the child is weight gain, whatever. What about the weight gain? Did you ask
Child
any?
is of short stages, sir, and is of normal weight gains. Normal weight
Yeah,
gains.
yeah. So the nutrition also is important. Okay, you will be presenting the other things in subsequent slides. Continue.
Yes, sir. A past history, the child was diagnosed at birth with Down syndrome with dysmorphic facies and was confirmed by karyotyping and is on regular follow-up. The child had similar episode at 6 months of age and was admitted in the hospital for 4 days, and nebulization was given 3 times a day. No history of recurrent respiratory tract infections.
So when did you say recurrent respiratory tract infections?
6 episodes for 1 week with 3 documented hospital admissions, sir.
1 year.
Then when you say recurrent pneumonia,
So more than 2 episodes of pneumonia present in 1 year with 4 weeks of difference between the 2 episodes requiring hospital admission.
one more thing, more than 3 episodes at any time, but in between the X-ray should be normal. That is also included
Yes.
in the definition.
Yes, sir.
Okay, proceed.
Yes, sir. Antenatal history. The mother's age at conception was 36 years. Pregnancy was confirmed by a urine pregnancy test and registered at RMH. Booked and immunized. Mother came for regular antenatal checkup. First
So
trimester.
here, the mother's age is 36. In what way it is significant in this case?
Sir, 95% of the Down syndrome is due to meiotic non-disjunction, and the risk of meiotic non-disjunction increases with age. And more than 35 years, the risk is 1 in 270 females. And more than in more than 40 years, it is 1 in 100, sir. That's why the maternal age is important.
What is the general incidence as a whole of Down
So 1 in 733 to 1 in 800, sir.
So if the mother's age is around 45, almost it will be around 1 in 40 or
140.
150, 40. Yes, sir.
Okay. Yes, sir.
Yes, sir. First trimester, 2 doses of TD were given. No history of excessive vomiting, no history of exanthematous fevers, no history of irradiation, no history of drug intake other than the prescribed drugs. Dating scan was done and was found to be normal. Second trimester, quickening was felt at 5 months. Iron and folic
Doctor.
acid tablets taken regularly. Yes, sir.
Yeah, the first trimester usual history what you have taken is right. That is what we usually present. But in case of Down syndrome, it is better to highlight if whether they have done some Down syndrome screening and all.
Yes, sir. The
Just to
maternal screening was
just
not
to-
done in this case.
Yeah, if you mention that, the examiner will think, okay, they have asked for Down syndrome screening. They are aware of it. So just to show that, you know that it is a important test that has to be done. Okay.
Yes,
Yeah.
yes, sir. Yes, sir. And in second trimester, quickening was felt at 5 months. Iron and folic acid tablets were taken regularly. No history of a gestational hypertension or gestational diabetes mellitus. Anomaly scan was done in 5 months and was found to be normal. And maternal serum markers were not done in the second trimester also, sir. Third trimester, continued to perceive the fetal movements. No history of urinary tract infection, other infections in the mother. No history of bleeding per vagina. Iron and folic acid tablets were taken regularly. Growth scan was done in 9 months and was found to be normal.
So
Birth
what is your opinion about the antenatal history and antenatal history? Whether they are done it correctly,
Usually, the
not whether
antenatal
the
history,
screening done or not.
yes, sir,
Prenatal
antenatal
fetal karyotyping was not done, sir.
What are the
Despite
what are the screenings usually being done?
dual test can be done, sir, which includes PAP-A and beta HCG, and triple test can be done. Beta HCG and beta HCG is increased.
Unconjugated estriol and alpha fetoprotein are decreased, sir. So that's a triple test, sir. Usually in the first trimester, nuchal translucency is checked in USG, and a double test is done. In the second trimester, triple test and quadruple tests are performed, sir.
What is quadruple test?
Sir?
Triple
What
test plus
test?
inhibin, sir. Triple test plus inhibin.
So what is meant by integrated test?
Nuchal translucency plus PAP-A plus quadruple test, sir.
So Pradeep sir, can you highlight
amongst these tests, what test you would prefer? Which will have the highest detection rate amongst these three?
the quadruple test.
How much is that?
So the sensitivity.
85% 85% sensitive, sir.
Which one? Quadruple?
Yes, sir.
No.
95%, sir, in quadruple test.
No. The 85% is for first trimester screening. So NT-FTS has the highest detection rate here. Okay.
Yes.
So quadruple is the second best because it can detect up to 75, around 75. but triple 75 to 80, but triple marker is an inferior test comparatively because it detects only up to 65 to 70%. So order-wise priority is anti-FTS first trimester screening. If they've missed that, then you can suggest quadruple, not triple, at the second trimester.
Yes, sir.
Okay.
Yes,
So along with it, we have to add the sonological, sonographic findings also. So what are all the soft markers you know of? Some clues for Down syndrome baby.
The nuchal translucency.
Soft fever will be seen in the UST, sir.
Pardon
Nuchal
me?
translucency will be
NT, okay.
Nasal bone will be
increased,
absent, sir.
Nasal bone delayed or absent, okay.
Delayed absent.
Short femur is seen.
Okay, that is a little late.
Renal pilectasis can also be
Good.
seen.
Then
Duodenal atresia and increased intestinal echogenicity.
those are pathological findings, real pathological findings, AVST. What are the cardiac manifestations you can see antenatally? Endocardial cushion defects. So AVSTs.
Yes,
The
sir.
soft markers I'm asking. Soft markers? What can be seen in the heart? Intracardiac echogenic focus.
Yes, sir.
Yes, sir.
And then renal, and then in the heart again? Aberrant right subclavian artery. ARSA also is a added finding. So these are soft markers, which based on that also we can do the risk detection. But basic screening, these three are very, very important. Amongst these three, you should know which is superior.
Yes,
okay.
Sir.
Yeah.
Yes, sir.
Yes, sir.
Yes, you can proceed. Birth history.
Yes, sir. Birth history. Full-term normal vaginal delivery, male baby, weighing 2,700 grams at birth, delivered at RMH Tanjavur. The baby cried immediately after birth. Neonatal history. Breastfeeding was initiated within a half an hour of birth. The baby passed meconium within 24 hours after birth and passed urine within 48 hours after birth. Not an NSU graduate.
So, in this neonatal history, you can add whether there is any prolonged jaundice. So, what are the reasons for prolonged jaundice in Down syndrome, particularly in the neonatal period?
Annular pancreas.
Annular?
Sir, hypothyroidism.
Pancreas sprung diseases are common, sir. So there can be constipation, which leads to increased intrahepatic circulation, which may predispose for jaundice, sir.
Okay.
And hypothyroidism can also be a cause.
Okay, proceed.
At birth, how will you, any markers for diagnosing the Downs? Like this
meconium passage, sir.
Poor Moro reflex also.
Yes, a poor Moro's reflex is seen, sir.
Okay, other thing you told. Thank you. Continue.
Developmental history. Currently the child is able to run, which is usually attained by 18 months of age. Hence the developmental quotient is 30%. And fine motor skill, the child is able to currently draw only horizontal lines, which is attained by 18 months. And again, the developmental quotient is 30%. Socially, the child parallel play is seen, which is usually obtained by 3 years, and the developmental quotient is 60%. And the child only jargon speech is present, which is attained by 15 months. Hence, the developmental quotient is 41.6%. In this child, since the more than 2 is involved, it is said to be global developmental delays present. So,
can you tell what he is capable of? What and all he is able to do?
Sir, gross motor he is able to run, sir, but without support he cannot climb the stairs and all, sir. And in fine motor only horizontal line is drawn, sir. Further circle, triangle, all those cannot be seen, sir. And in social there's only parallel play, sir. And child is not able to speak comprehensible words.
Okay. Is he able to express his needs?
Yes, sir. He's able to express his needs, sir, but he's not able to perform its activities, sir.
Toilet trained?
Yes, sir. He's able to ask for those things, sir, but he is not able to perform them without anyone's help, sir.
Okay. He's able to perceive that.
Yes, sir.
Okay. Okay.
So the developmental delay is expected in the Down's babies. So at 5 years, we have to assess the intelligence also. After up to 3 years, we can put as the DQ, developmental quotient. After 3 years, you have to assess the intelligence also, IQ also you have to assess.
Yes, sir.
Okay. Okay. So what is the IQ, maximum IQ the Down's Down syndrome person can have?
Sir, 50 to 70, sir.
Moderate
Moderate and
delay
disease
will be
present,
seen,
sir.
sir.
Disability.
What is the average IQ of Down syndrome patient? Average is 50.
50.
52.
So it's in the range from 30 to 70, average being 50.
Yes, sir.
Yes, sir.
So what are the social problems, social interactions? So how can he interact with the other persons? And all, what is the problem? Can you explain? So he may be
Sir, the
having the
child is
problem in
able to have
expressing.
parallel plays. Yes, sir.
Communication,
He's
they
able
may
to
be
parallel
difficult
places.
to communicate
Yes, sir.
with
He
the
is able
others.
to play in groups, sir. Yes, sir.
Very
He's able to
that
play in
history is very,
groups.
very important. Nice that sir has brought out that, because why
Yes,
we are
sir.
worried about how the baby is getting along with the others. What is that risk we are more worried about? The
So that
social
could be
interaction.
autism.
Yeah, how much percentage they are associated with Down syndrome?
So some 15%, sir.
15 to 20%, but that is
20.
actually a bad combination. A child with Down syndrome and having an autistic spectrum disorder, it will be very difficult for the parents to bring the child up. If it is not associated with autism spectrum disorder, how the children will be?
So
About the
Otherwise,
social
the child will be
language.
very playful, sir. Playful, sir.
Very socializing, very friendly. So
Yes, sir.
were you able to feel that? Did you interacted with them? How was he interacting with you? Was he social, friendly?
Playful child only, sir.
Okay.
Friendly and playful, sir.
Okay. You just have to see that how they are behaving with you. That is very, very important to differentiate between
Yes,
other
sir.
genetic disorders and these children. How well they are
Yes, sir.
interacting. So that is their strength.
Yes, sir.
Thank you. And you can proceed.
Yes, sir. Immunization history. The child is immunized up to age. According to national immunization schedule, last immunization was given at 18 months of age. DPT first booster, vitamin A, MR second dose, and JE second dose was given. Contact history, there was no history of contact with tuberculosis. Nutritional history, sir. The required calorie
Given
intake
the
is
history, this child has presented with a lower respiratory tract infection. What other immunizations you would advise or you'll ask for whether they are giving?
So pneumococcal vaccination,
vaccine.
sir.
And seasonal flu vaccines also.
Yes, sir.
Okay. Yeah.
Yes, sir. Nutrition history, the required calorie intake is 1350 kilocalories, and the child has a calorie deficit of 191 kilocalories, and the required protein intake is 20 grams. The child current intake is 21.6 grams, and so there is no protein deficiency. Calorie deficit is 191 kilocalories, sir. Family history, the child belongs to nuclear family. The child is of second order, born out of non-consanguineous marriage. There's no history of Down syndrome in the siblings. Age of father currently is 46 years, and the age of mother is 41 years at present. The child has an elder sibling of 12 years of age, and currently the child is 5 years.
Why you have asked for history of Down syndrome in siblings?
Sir, because when a translocation is present, there is a history of recurrence in the next sibling, sir.
Okay.
If
So
translocation 21, there is 100% risk. Yes, sir.
Okay. What does this child has? What chromosome pattern this child has?
So it's commonly meiotic
No, what
non-distinct.
he has.
Meiotic
Sir, he has
He has
trisomy 21, meiotic non-distinct.
So 21 pure non-disjunct type of chromosomes, right? This child has that one only. Okay.
Yes, sir.
Okay.
Yes, sir. Shall I proceed, sir?
Yes, please.
Yes, yes.
Yes, sir. Socio-economic history. Total number of family members is 4. The number of earning members is 1. Hence, the dependency ratio is 1:4 with per capita income rupees 5,000. Based on according to modified Kupasamy scale, the family belongs to upper middle class too.
So what
Environmental
is the
history.
importance of socioeconomic history?
Sir, children belonging to low socioeconomic status are more prone to infection, sir. And
Then-
also it tells the reliability based on the mother's education status. It tells about the reliability of the informant.
And if they are in present in the high socioeconomic state, excess care can be given for the child. So a child being a Down syndrome child, excess care and attention is required for the child's adequate development.
So they have to undergo multidisciplinary management. So in our government setup, we have the district early intervention center. They can come here. But if they are not coming to government setup, they have to pay more for the multidisciplinary managements.
Yes, sir.
Yes, sir. Environmental history. The child lives in a Pakka house with good lighting and ventilation. The house has separate kitchen and toilet facilities, proper disposal of garbage, and uses municipal water supply. Case summary. A 5 years old child who's a known case of Down syndrome with previous history of hospitalization for respiratory tract infection at 6 months of age with delayed development of milestones, presented with the chief complaints of productive cough for 1 week, fever for 3 days, and breathlessness for 1 day.
So what are the systems involved in this?
So usually Down's is a multi-system involvement is seen, sir. Currently, the child we expect the child to have respiratory tract infections involving the lower respiratory tract, sir.
And the CNS involvement is also there as there is delayed development of milestones, sir.
So what else other than that? Thyroid we have ruled out. Huh? Thyroid testing has been done?
Yes, sir. Thyroid test was normal, sir.
Normal.
There's
After
no
evaluation for refractory errors.
Yes, sir. The patient is on a regular follow-up, sir.
So can any one of you enumerate from head to toe what are all the findings you can expect in a Down syndrome child? With that, we can plan how these children can be managed based on the system involvement.
Yes, sir.
Head to toe, few findings.
Yes, sir. Head, it's usually microcephaly, sir. Small head is seen, and coming on to eyes, it will be that will be an.
That is not the usual finding. Not always common microcephaly, but the most common is your delayed anterior fontanel closure.
Okay, sir.
And they may have brachycephaly. Microcephaly, of course, is present. Tell me. Then?
Yes, sir. In the eyes, upward slant of eyes is usually seen, sir. And epicanthal folds are seen. Depressed nasal bridge and dysplasia of the ears. Extra skin folds.
Eyes again. Sorry to interrupt. Actually, you are seeing some physical findings, well and good.
Yes,
same time, you tell me about the functional findings also. Physical findings,
sir.
you are not going to change anything. Okay.
Yes, sir.
So the angling of the eyes, we are not going to do anything. But the functional is myopia. So if you concentrate that, we know what and all care any child will have to get. Okay. So functional also you concentrate. Tell me.
Yes, sir. Functionally, in the eyes, refractory errors are common. Among the refractory errors, myopia is common. Otherwise, cataract can be seen, or squint eyes can also be present.
So what age this cataract are common?
It is more common in less than 1 month, or it occurs only in the adolescence, sir.
So you have to screen annually or periodically.
Annually, ophthal evaluation is needed. So from your findings itself, we know ophthal definitely these children need to check. What next?
Then hearing. Yes,
sir.
Hearing aids also has to be checked, sir. By using the brainstem evoke the response thing, the hearing can be checked, sir. Usually serious otitis media is common, which causes conductive hearing loss, and also due to a narrowed internal acoustic meatus, sensory hearing loss can also be seen in these patients. So a screening must be done annually for hearing impairment.
So this also has to be looked every now and then.
Yes,
Next.
Next is Atlanta axial dislocation is common in these children. So usually lateral neck x-rays must be taken at 3 to 5 years or before if any the child is going to perform in any sport activities.
Neurological examination also.
Yes,
then
sir. And your neurological examinations will be
physical
carried
finding
out,
in the neck is redundant fold of skin and short
yes,
neck.
Yes,
Then
X-ray chest can be taken, sir, to rule out any congenital cardiac anomalies, and usually 11 pairs of ribs are normal, and there is a dysplastic 12th rib is seen. Sometimes 2 or more ossification centers in the manubrium sterni can also be seen, sir.
Functional lungs and heart. Tell me.
Yes, lungs, pulmonary hyperplasia is usually common. In the heart's endocardial cushion defects, ventricular septal defects, or aberrant subclavian artery, isolated secondum atrial septal defects are usually common in the
lungs, recurrent pneumonia also. Okay.
Yes, sir.
ENT in the mouth, we left mouth.
Yes, sir. In the mouth, a small mouth with the normal tongue is seen. So relative macroglossia is present in Down syndrome. High-arched palate is seen in a Down syndrome patient, and delayed dentition or irregular dentition is seen in patients.
They are prone for dental caries also. So dentist opinion also may be needed. So
yes,
then
sir.
the obstructive sleep apnea you were telling.
Disease also common, sir.
Yes, sir.
Then in the tongue, what abnormality can expect? Tongue. What about the surface of the tongue?
Hypertrophy of the papillae can occur, and the fissuring of the tongue can occur. In adults, a scrotal tongue.
Okay, hypertrophy initially it will be common in the age group of 1 to 2 years.
1 to 2 years.
1 to 2 years.
Fissuring will be common in the age group of 3 to 4 years.
3 to 4 years. Yes, sir.
Okay.
GI, gastrointestinal.
Is in GI, duodenal atresia from the start, tracheoesophageal fistula or duodenal atresia, biliary atresia, or any intestinal atresia is common. Annular pancreas are common, sir.
Imperforate anus also.
Imperforate anus is also common, sir.
Genital.
Genital tract.
Disease.
Yes, sir.
Disease. Genital.
Genital, usually the females can be fertile, whereas the male Down syndrome patients are commonly sterile because of a small penis or a cryptorchidism or a cessation of spermatogenesis. So the male Down, yes, sir. Hypogonadism, the male child is usually sterile, sir.
Okay. Musculoskeletal.
In the musculoskeletal, generalized hypotonia is seen, and hyperflexibility of joints can be seen. In the fingers, clinodactyly is seen, so hyperplasia of the middle phalanx of the little finger.
Transverse crease.
Single palmar transverse crease can be seen, or Sydney line can also be seen, sir. Coming on to
right?
As a dislocation of the hip. So smaller acetabular angle, so they're more common for dislocation of the hips. In the soles, increased distance between the great toe and the second toe, sandal gap can be seen, sir. And the Kennedy crease is also seen, a deep sole crease between the first and the second toe.
How common this simian crease, whether it is seen in the normal individual?
Yes, for about 3%, sir.
Okay. In Down syndrome?
Normal variant.
45%, sir.
It's around 40 to 50%.
So based on all the findings, so what is the conclusion about this management of this child?
Sir, we'll finish the examination point part also.
Okay, sir. Okay,
sir. You continue the examination, general examination, systemic examination.
Yes, sir. A general examination, the child was seated on mother's lap during examination. Child was conscious, oriented, alert. There is no pallor, not icteric, no cyanosis, no clubbing, no generalized lymphadenopathy, and no pedal edema. Vitals, the pulse rate was 126 beats per minute, a normal in rhythm, no specific character, normal volume, measured in the left radial artery. Respiratory rate is 42 breaths per minute, which is tachypnic for this age group. Blood pressure is 90/60 millimeters of mercury, measured in the right upper arm in the sitting posture. The child is currently febrile with a tension of 101.4 degree Fahrenheit, measured in the right axilla using digital thermometer.
So what is your interpretation
Head-to-toe
in the
examination.
vitals examination? What is your interpretation?
So vitals, the child is currently febrile, sir. 101.4 degree Fahrenheit. Also, due to fever, there's also a rise in the respiratory rate and pulse rate, sir.
Blood pressure you measured. Is it normal according to the age and all you have to see, and whether it is checked in other all four limbs, whether it is checked or not, you have to see. Then respiratory this tachypnea is there, so maybe some respiratory illness, viral pneumonia or bacterial pneumonia may be there. Okay, you continue.
Yes, sir. Head-to-toe examination in the head, microcephaly, flat occiput, flat facial profile is seen. The hair is sparse. Eyes, there's upward slant of eyes. Epicanthic folds are present. Hypertelorism. There's no brush field spots in the iris. Nose, flat nasal bridge is seen. There's small mouth with protruding tongue. There's no cleft lip or cleft palate. Dentition is irregular, and there are no signs of dental caries or periodontal disease. Low set ears.
There is some. Here you have mentioned that there is upward slant of eyes. Where will you get antimongoloid slants? What is meant by antimongoloid slant?
When the outer canthus is at a lower level than the inner canthus is termed as antimongolian slants, sir.
So you able
It's
to
usually
tell some examples.
Yes, sir. In Turner syndrome, Noonan syndrome, Alport syndrome, antimongolian slant is seen, sir.
Treacher-Collins syndrome.
More common is Treacher-Collins.
It's a Treacher-Collins syndrome.
So many deletion condition can expect this. Okay. What is meant by brush field spots?
It is a whitish speckling that is present on the iris, sir. Salt pepper iris.
Which zone it will be present, in the periphery or in the middle of the iris? In the mid zone of the iris, it will be seen.
Okay, sir.
Okay, proceed.
Neck is normal in this child. Simian trace is present. There's no clinodactyly. The spine and cranium are normal. Sandal gap is present. Genitals are normal. Anthropometry. The child is 15. The weight of the child is 15 kg, and the expected weight is 18 kg. Hence, the child is between third and 97th percentile. The height is 98 centimeters, and the expected height for this age group is 107 centimeters, and the child is less than the third percentile. And circumference, the observed circumference is 47 centimeters, whereas the expected is 51 centimeter, which is less than 3 standard deviations according to WHO growth chart. This the child is of short stature, sir, and normal weight is present, sir.
Usually, it is better to use Down syndrome chart. I don't know, sir, what we are practicing in general pediatrics, but we would advise to use maybe for the case presentation, it is fine. Generally, we use Down syndrome specific charts for these children.
Okay, sir. This is undergraduate level they are presenting.
So, yes, sir. So I can understand, sir. Yes, sir.
Yes, sir. Yes, sir. Then any other comment of the general examination findings in this child?
So actually, we've covered it previously. I didn't see this one. So we've already covered, sir. Yes.
Okay, sir.
And regarding the dermatoglyphics, any abnormalities you can expect in Down syndrome. Only with lens you can be able to identify, but for theoretical aspect, what dermatological abnormalities you can expect in Down syndrome?
Sir, large ATD angle is seen, and radial loops is present in the 4th and 5th fingers, and ulnar loops on the 1st, 2nd, 3rd, and the 3rd fingers, and loops are present in the 3rd interdigital areas, and
so what would be the universal distribution of regarding the pattern of ridges whether it is a world pattern or loop pattern.
World pattern is present.
World pattern.
Generally,
Loop pattern is seen in the ring finger, sir. All of the fingers world pattern.
in the middle and little finger, it will be loop pattern generally. That is universal. All other fingers, it will be a world pattern. But in Down syndrome, almost all are loop, and particularly radial loop will be in the 4th or 5th digit. Okay. So what is the ATD angle?
So the points
So
are
the
marked
three
where
ridges. So the 3 ridges, we mark the points where the 3 ridges meet, sir. Near at the base of the index finger is marked as A, and the base of the palm is T, and D is at the base of the little finger. Usually, this angle is between is acute, sir, 43 to 74 degrees, and is less than 43 degrees. And this angle increases, it is a suggestive of Down syndrome.
So generally, it is around 40 degree, and in other, not only Downs, even Patau, Edwards, all others, the angle will be increased. So anything less than 90 is acute only. Everything is acute. Only thing from 40 to almost 70 it can increase. Patau will be having the maximum around 72 or so.
74.
In between will be the Down syndrome. Okay. So ATD angle is again and again they will be asking in the short notes for you. So you'll be thorough with that. Okay.
Yes, sir.
Okay.
Yes, sir. Systemic examination, upper respiratory tract. There are no anatomical defects, no nasal flaring, no nasal discharge. Nasal septum is present in the midline. Oral cavity, the tonsils are enlarged, not congested. Lower respiratory tract, on inspection, a trachea appears to be in the midline, chest is symmetrical, apical impulse is not visible, no audible wheeze or grunting, no dilated veins, scars or sinuses, no chest wall indrawing. Palpation, inspectory findings are confirmed. Trachea is in the midline. Apical impulse is felt in the left to 5th intercostal space in the mid-clavicular line. Ocal fremitus is normal in all the lung fields. Percussion, resonant note is felt over all the lung fields. Auscultation, bilateral larynx is present. Normal vesicular breath sounds are heard. Crackles are heard over the left intrascapular area. Cardiovascular system, the first and second heart sounds are heard. No murmurs. Abdomen, soft and no palpable organomegaly is present. Central nervous system, higher mental functions. The child is alert, awake, and the sleep pattern is normal. Motor system, the bulk is normal. Generalized hypotonia is seen in this child. The power is grade 5, which is normal. Superficial and deep tendon reflexes are found to be normal. Provisional diagnosis, a 5-year-old child who is a known case of Down syndrome with microcephaly with a global developmental delay is suffering from a lower respiratory tract infection, probably pneumonia.
So in cardiovascular system, what are the things you want to examine? Murmur, or expecting to about what are the murmurs you are expecting in cardiovascular system in Down syndrome? So what are the diseases?
A pansystolic murmur.
Where will you hear the murmur? In where?
Sir, pansystolic murmur in VSD, sir.
Left lower sternal border. Okay.
The common thing is endocardial cushion defect. No, it's endocardial cushion defect. What are all the findings you may expect?
Diastolic murmurs will present, sir.
Regarding the split, what type of split it will be?
Fixed split, sir.
Fixed split. Okay. Okay, which is common in this? Is ostium primum or secondum? In Down syndrome,
Second
which
term.
is
Second term is common.
Second term, sir.
no. In Down syndrome, primum is common. Which will have a better prognosis, second term or primum? Generally, second term will have a good prognosis. They won't go for a congestive cardiac failure. But primum, they may end up with a congestive cardiac failure. Down syndrome is common.
Yes, sir.
Patent ductus arteries is common. It's not common. It's also, you have to expect the patent ductus arteries murmur also from the examination, cardiac hospital examination.
Yes, sir.
Okay.
So, what is meant by Hall's criteria? Anything?
It is the diagnostic criteria based upon the clinical features for Down syndrome, sir. It includes 10 features. First one is hypotonia, poor morose reflex, flat facies, and slanting palpebral fissure, dysplastic ears, and hyperflexibility of the neck, and excessive skin tissue over the neck, and single transverse palmar crease, and clinodactyly, which is the hypoplasia of the middle phalanx of the little finger, and pelvic dysplasia is seen, sir.
Of which 4 out of 10 is seen in 100% of the cases, and 6 out of 10 is seen in 89% of the cases, sir.
Okay. While you're telling about dysplasia of the hip, if you take an
Yes, sir.
X-ray hip, what finding you can expect in Down syndrome?
Iliac index is less than 60 degrees, sir. Iliac angle plus acetabular angle.
Then flaring of the
And
iliac wings
flaring
are
of
seen.
iliac wings.
So, what is that shape called? That flaring of the iliac bones,
Mickey Mouse appearance, sir.
or elephant ear
Yeah.
appearance?
Elephant
Yes,
ear.
sir.
Yes, sir.
Okay.
So the final diagnosis. Again, tell the diagnosis.
Yes, sir. So a 5-year-old child who's a known case of Down syndrome with microcephaly with global developmental delay is suffering from lower respiratory tract infection, probably pneumonia, sir.
Okay.
What are all the
Sir?
management, sir? Sir?
Yes, sir.
Yes, sir.
You want to take?
Yes, sir. Management options only I wanted to ask.
Yes, sir. You continue, sir.
Yes. So this child has presented with acute respiratory illness. That obviously we are going to treat it. So what is the long-term follow-up advice you will give for this family?
A multidisciplinary approach should be done, sir.
Okay.
And early stimulation should be done, and the patient may be referred to a early stimulation center, intervention center, early stimulation intervention center, and the patient should be educated in special schools, sir.
No, for this child you tell, and then for regular other Down syndrome children, general management you tell. For this child, 5 years old, with what are all the problems you had in development, and what advice you are going to give for this child?
As the first, the child has developmental delay, sir. So extra care must be given for it, and the parents must sit beside the child, and they have to stimulate for each and every action, and they must encourage the child for the performing action, so that the child can perform its daily activities.
So, what is the goal you want to achieve at 5 years now?
5 years, according to gross motor, the child must be able to go upstairs and downstairs on its own, and the fine motor should be able to dress and undress on its own. And on speaking, it must be able to ask meanings of words to the parents, and must be able to speak fluently. So for all these things, the parents must encourage the child to perform all these activities.
Fine. If these are achieved,
so yeah, yes, sir.
So this child is lacking all this.
Yes, sir.
And another thing is your toilet training. So all these should have been achieved by at least 5 years to put the child in a primary school.
Yes, sir.
Okay. So this is the focus you will have on this child. for a regular or Down syndrome child, how early the intervention should start? You are telling about early intervention, no?
Yes, sir.
By 2 to 3 years, sir.
No, that is very late, man. 3 to 6 months. That is the time for early intervention. Okay.
Yes, sir.
Yes, sir.
So we know that this child is going to get the milestones in a delayed time. So we want to catch early, start giving them early interventions so that they reach the respected development at the respected time. As early as possible, we have to achieve that. So primary goal is to make the child
Perform its own activities on its own.
by at least 5 years,
At
so
least
that they
5
can
years.
be put into normal
For
school.
primary school.
Okay, so this is for the development part. What other organs you will advise for this child for follow-up, and for the regular Down syndrome children, what are all the specialized interventions or follow-ups needed? Just list it.
Sir, annually ophthalmologic evaluation is required, sir, and audiological evaluation. And hypothyroidism should be tested every 6 months, sir. Cardiac abnormalities should be ruled annually, should be done, sir. Atlantoaxial subluxation should be tested from 3 years of age. And we need to, when the complementary fetus started, celiac disease should be ruled out by doing tissue transglutaminase and IgA antibody levels screening.
Then, so basically they develop.
Leukemia should be complete blood count should be done, and therapy for the leukemia, sir.
And physiotherapy is necessary for the patient to walk and for all the joints to move properly.
So multidisciplinary involves all these for these children. Okay.
Yes,
sir. Sir, anything else?
That why did you ask the blood examination? What are the blood examination? Peripheral smear,
complete blood
check.
count and peripheral smear. Look for blast cells, sir.
Yes. So how periodically you want to check the hematological problem?
Sir, when the patient is symptomatic or it is done annually, sir.
Okay. So, is there any surgical corrections that can be done in Down syndrome for the cosmetic or for something else?
Yes, so cosmetically, plastic surgeries, plastic reconstructions can be done. So facial reconstruction or lateral canthoplasty can be done for the upward slants, or zygoma enhancement can be done, sir.
Partial glossectomy for tongue relative macroglossia can also.
So, what is the usual cause of death? Which is what are the common causes in which the patient dies in Down syndrome?
Common is because
mostly it is due to cardiac abnormalities, sir. Also, patient may die of leukemia and sudden death due to atlantoaxial subluxation or obstructive sleep apnea syndromes. Common, sir.
Due to pneumonia, sir.
Even pneumonia is one of the common cause of death because the natural immunity is less, no? So it's very difficult to treat with the routine antibiotics. So
surgical reasons comes first, particularly in the infantile period itself. So gastrointestinal surgical issues like bowel obstructions, cardiac abnormalities, then your atlantoaxial dislocations, leukemias, and then little late onset problem, little late for Down syndrome, but early for Down syndrome, early Alzheimer's disease.
Yes, sir.
So that again is a reason for cause of death for these children. So can you tell about, sir?
What is the life expectancy of Down syndrome nowadays?
50 to 55 years, sir.
Okay. Previously it was less, but with so many advanced surgeries and then now it has become increased.
Yes, sir.
You were talking about the chromosomal pattern. So can you tell me about that? What are all the types based on the chromosomal pattern? Why is it so important?
Sir, in Down syndrome, mostly meiotic non-disjunction is seen, sir. In meiosis 1, a non-disjunction occurs. Therefore, trisomy 21 is most commonly seen in 95% cases. Also, there could be translocation, which is seen 4%, and 1% there is mosaicism is seen. Both non-population and abdominal cells are seen in mosaicism. And if the maternal age group is increased, there's increased the chance of amniotic non-disjunction. And in lesser age groups, translocation is more common. And based on the translocation, based on the translocation typing, we can predict the risk of recurrence, sir. If there is a translocation 21-21, that is 100% risk. There is translation between the D and G group of chromosomes, that is 14 and 21, the risk is 5 to 7%.
15% if female is a carrier. No, you start
Yeah,
from first.
yes,
So based on the chromosome, you are going to predict the recurrence risk now. Okay.
Yes, sir.
So first is
First carrier
non-disjunction.
typing. Yes, sir.
Carrier
Carrier
typing,
typing has to be done,
non-disjunction.
sir. Yes, sir. Non-disjunction. And if non-disjunction is ruled out, then we do either fluorescent
for non-disjunction,
hybridization.
what is the recurrence risk?
1%.
1%, sir.
Less than 1%. Okay.
Yes,
So
sir.
next is your translocation. That is for 4% of the children may have translocation. In translocation, how will you predict the recurrence risk?
If a mother has the translocation, there is a risk recurrence of 10%. If father is a carrier, the risk recurrence is 5%, sir.
If both are not carriers,
no risk.
Recurrence is very, very low. So you just have to know that translocation, if only parents are carriers, it has increased recurrence risk. Mosaicism again has less recurrence risk. So this is important when you are counseling for next pregnancy in the same family.
Yes, sir.
So what are all the early identification options available for next pregnancy? For non-disjunction or regular screening methods? And where will you go for prenatal testing and all? So usually non-disjunction, mosaicism and all have less than 1% recurrences. There you don't need to tell the family about the fetal testing. Fetal testing means in fetus chromosomes testing. Otherwise, these families only need the regular screening test, what you have told, first trimester screening and quadruple testing. If there is a translocation found in parents, that family, the recurrence can be up to 50%. So they need prenatal testing of the fetus for chromosomes. Okay, in that way, this is very, very important.
Yes, sir.
Yes, sir.
Okay. Sir?
Any non-invasive test that can be done? What type of non-invasive test?
Maternal
self-fetal DNA is usually seen in the maternal circulation, sir.
So, among this non-disjunction, translocation, and mosaicism, which one will have almost near normal IQ?
Mosaicism, sir. Mosaicism.
Why?
Because it has a normal set of chromosomes as well as the abnormal set.
Actually, in the first division, there won't be any problem. So subsequent division only there will be problem. So most of the cells will be normal.
Sometimes you can, you have some, it depends on the percentage of normal cells versus the, trisomic cells. So it depends on which organ has how much amount of percentage of the trisomy 21. So generally, mosaicism, they perform relatively well than the regular Down syndrome children.
Yes, sir.
What is the isochromosome?
So an isochromosome, when one arm is deleted, the other arm gets duplicated and both arms are similar, sir.
No, sometimes the long arm may be carried to the next. Usually one short arm and one long arm is carried to the next generation. Whereas here, long arm alone may be carried to the next level. So that is also one way of triple chromosome that occurs in the control. That's a very rare type. Is it so, sir?
Do you know of any parental association for Down syndrome children? Dr. Yalini?
Sir?
Parental associations.
So the
Parents of Down syndrome association, Down syndrome children, no, they have an association called Down syndrome association. Okay.
yes, sir.
So this family has to be registered under them, so that all the other social issues, their education, their schooling, their higher education, their vocational training, their job opportunities, all these, those parental associations will help these families. Okay, that also you should know that this is available, very much available in our country. They are very active also.
Yes, sir.
Yes, sir.
What is occupational therapy? What do you tell something about occupational therapy? What is the role of occupational therapy in this Down syndrome, Down child?
Sir, as far as the pediatric age is concerned, occupational therapy mainly concentrates on making the child to perform activities of daily living, sir.
Okay, whether they can marry and have the normal life like others. What about the advice you will give to the parents about the marriage and all? What is
Yes,
you
sir.
said
If
they're
the
having
Down
the life expectancy of up to 50 years. They have to think all these things.
Yes, sir. Yes, sir. We have to I counsel the parents regarding all the facts about the Down syndrome, sir. So, then regarding the marital life, if the patient is a male baby, then confirm the child will be sterile. He cannot give birth. He'll be sterile for life. Whereas if it is a female child, there are chances for normal reproductive functions, sir.
Because you told about this, what will be the recurrence risk if a mother with Down syndrome carries a baby?
50%.
The risk will be 50%, sir.
50%, sir.
So definitely she has to undergo amniocentesis or chorionic villus sampling for fetal chromosome testing. Definitely
Yes,
that
sir.
mother has to undergo.
Yes, sir.
Yes, sir.
What is meant by anticipatory guidance? Just nothing but what we have told already. That is, we have to instruct what are the future complications and we have to follow out. No? So that you have to explain it in detail in the early period itself, so that the parents will be well prepared for that. So in Down syndrome, that is more important. It's a long course, no? So they have to tell at what stage what complication may arise, and we have to guide them in such a way. So that you call it as anticipatory guidance. That is very important in Down syndrome follow-up.
Yes, sir.
Yes. Shall we finish with this, sir?
Yes, sir.
Anything further the students are going to present? This is the last slide, I think so. Any other slide? No other slides.
No, sir,
Okay.
that's all, sir.
Okay. Then, sir, Pradeep, sir, anything you want to add more?
Yes, sir. So nothing
Nice
much, sir. They
discussion.
covered very well.
Sir.
My appreciations. Yes, sir. Definitely they were presented very well. Didn't
Yes,
seem
sir.
to me
Thank
like
you,
a
sir.
UG
Thank you.
presentation at all. So my appreciations to them.
Thank you, sir.
Thank you,
They fine discussion. I also learned many things from the students, also from Dr. Pradeep sir and Sendil sir, and nice presentation. So Dr. Sendil, you also tell your. So I thank Dr. Suresh Balan sir and Dr. Rajendran sir and Dr. Tirumurugan sir for giving the opportunity. And it's a nice thing for conducting the UG clinics. Dr. Sendil, you also tell
Definitely,
something.
sir. All these three students were very interested in presenting, and right from the beginning, they are preparing well. So, my best wishes for their future careers.
Thank you, sir.
Thank you, sir.
Can you hear me?
Yes, sir.
Yeah. Okay. Next presentation. Okay. And I have only one question. Why the Down syndrome babies are more prone for respiratory infection?
Sir?
Sir,
Why
there may be like
Down syndrome babies more prone for respiratory infection?
sir, in a Down syndrome, there is hypotonia of the neck muscles, sir. And also there is relative macroglossia, which could lead to aspiration, sir.
Okay.
And the
And
patient
congenital heart
is
defects are also present.
immunocompromised also.
No compromise. Any other answer can you tell? Any
Due to
anatomical,
congenital heart defects, sir.
any anatomical defect in the alveoli? Usually babies having double capillary network on the alveolar wall. Okay,
Yes,
one
sir.
thing. Another one is alveolar ducts increase in size. Okay. Third one is there's number of alveoli also decreased.
Okay, sir.
Okay, this is the reason. Okay, these are children more prone one. Yes, you said many other conditions also. This is a basically defect in the Down syndrome babies. Okay. Now, apart from that, as you said, hypoplastic lungs and excessive pulmonary lobulation, these all things may contribute. Okay. Okay. The main thing is double capillary. It's network and the alveolar wall. Okay. And alveoli compared to normal children, these children are decreased alveoli. Okay. Okay. The excellent presentation. I think Dr. Balamurugan team. I think yes, you should not.
Thank you, sir.
Very calm. Achieve like thing. And I think Dr. Kumar, I think contribution also good. And Kumar, I think this genetic aspect discussed very nicely. And children, your children, the results are really done very well. And on behalf of IAP TNSC, I thank Dr. Balamurugan, Dr. Sindil, and
Dr. Sindil is the main mentor, sir. Mentor for students. He is very interested in teaching, sir.
Thank you, sir.
The main pillar of our department, sir.
Thank you, sir.
I think Yalini and Sarin, and I think the three of them are equally involved in the discussion. Okay, good. I think we really are boldly discussing. That's good. Okay, I thank one and all parties to thank you.
Thank you, sir.
Thank you, sir. Thank you for the opportunity. Thank you. Thank you.
Thank you. Thank you, Pradeep, sir. Thank you. Thank you. Thank you.